to have all of you here. A couple of housekeeping first before we get into all the fun stuff. There will be a short reception right out here. Am I pointing the right way? Right out here in this lobby afterwards, catered by Lacey's Fresh Fare. So for those of you that don't know, it's right here in K-State's Justin Hall and run by our hospitality management students. So they'll be catering that right after we're done here. For those of you, 12 I think I counted, registered dietitians in the room, we did get approved for one CEU. So at the end, you'll see the QR code that you're probably familiar with now that you can quick code if you want, and it'll load into your portfolio. And we have certificates that we can hand out as well. All right, so we're excited to see so many students here. We never know at 4 p.m. on this day if you guys are busy or not, so we appreciate you coming. And I wanted to also thank all the registered dietitians in the community that came. So if you're a registered dietitian, can you raise your hand? So we have we all clumped together, and then Mitzi's over here. Sorry, Mitzi. So we thank you guys for coming in, and for those that are online, I think we have some of our preceptors online as well. And I also wanted to thank a couple of people, or call out a couple of people. I saw Brian Linshield. So for those of you who don't know, he is our interim director of our Department of Food, Nutrition, Dietetics, and Health. I see Craig Harms, who's going to be the new lead of our new School of Health Sciences, which is where dietetics will fall as we reorganize the college. And then I want to thank those that helped put this together. So Heidi Albrighter for figuring out the new CEU strategy for us, Erica Linshield, Karen, who might be on Zoom with us, and then Dr. Shanklin, who you will meet here shortly. So I want to just tell you a little bit about Grace Shugart. I was not lucky enough to know her, obviously. I came about the time she was leaving K-State, unfortunately. But I did have her book, and we were just joking. Carol will probably share with you here that she has the book as well. So Grace Shugart, MSRD, 1910 to 1994. In 1951, Grace and her husband Harold moved to Manhattan, where she became the director of food service here at K-State for the residence halls. In 1957, after Bessie Brooks West, you might recognize the name West from West Hall here at K-State, she retired, so Grace stepped in and became the head of the Department of Institutional Management, which housed the dietetics program at the time. She was definitely committed to food service management, which is kind of my background, so I'm fangirling up while I'm talking about her. She was committed to food service management as a major component of the dietetics practice. She had the foresight to give her students educational opportunities such as management, even industrial engineering and computer science, because she knew those were things that dietitians were going to have to do in the field. So she had some foresight to think beyond just home ec, which is kind of what it was at the time. She co-authored 2 classic textbooks, one of which you're probably still using in some classes, Food for 50, and also Food Service and Institutions, which was later renamed as West and Wood's Intro to Food Service. Some people are shaking their heads that had this. Based on her own career pattern, she believed that dietetics faculty members needed experience in the field because they are responsible for helping our students figure out how to apply theory to actual practice. And I think we still hold to this today because many of our dietetics faculty were actually in practice before becoming faculty member in our dietetics program. So I think we're still pretty proud of that. In 1960, Grace became involved in the American Dietetic Association, now obviously called the Academy of Nutrition and Dietetics. She took an active role by first becoming involved at the state level with the State of Kansas Dietetic Association. In 1968 and 1969, she served as the president of the American Dietetic Association. Her term as president was highlighted by the implementation of registration and legislation, both of which greatly contributed to the public being aware of what dietetics practice was, and also it's kind of how we got our foot in the door to be true healthcare professionals. That credentialing was really important. Based on her extensive work and impact on the profession, she received not only the Academy's Medallion Award, of which we have at least 3 recipients sitting in the room, all Carols, by the way, all have received the Medallion Award, but Grace also received the Medallion Award, but she also received what is called the Marjorie Holsizer Kofer Award, which is one of the highest honors from the Academy. And she got that in, let's see, do I have the year on that one? I don't have the year on that one. Grace was a panel member of the 1969 White House Conference for Food, Nutrition, and Health, as well as the Committee on Human Nutrition and Needs for the state of Kansas. In addition to all these activities, she still mentored and taught many students and professionals throughout her career. When she received the Medallion Award in 1978, She was acknowledged for her high ideals, dedication, and personal integrity as a renowned teacher and educator. And how lucky were we that she did all of that while at Kansas State University? Our program likely wouldn't be where it is today without the efforts of Grace and how she got the world of dietetics to expand and get more attention. So this specific lecture began in 1975 to honor Grace Shugart. She left a legacy and was known for helping shape the profession across the country and in developing K-State's strong stance in management and dietetics education. Mrs. Shugart's tenure as department head positioned K-State as one of the leaders in dietetics education, and especially in the management aspects of practice. And today, the Department of Food, Nutrition, Dietetics, and Health is proud to welcome you to the 49th Annual Grace Shugart Lecture. I now ask Dr. Shanklin to step on up and introduce our speaker for the year.
Thank you, Kelly. I'm honored to introduce our speaker for the 49th Grace Shugart Lecture. Carol Arton Jones and I have gone way back. We won't say how far back, but Carol was in my first class I taught at Texas Tech University, which was purchasing, and we both survived the class. I don't ask her about the final exam, though. It's a legend in its time. Then Carol started her career as a clinical dietitian because she got her bachelor's degree in dietetics at Texas Tech, and then started her first career as a clinical dietitian at Parkland Hospital in Dallas, Texas, as a burn specialist. She then served as research dietitian in the Department of Surgery at the University of Texas Southwest Medical Center. It was during this position she started to work on her graduate degrees at Texas Women's University, where I had gone to at that point. And it was the outcome of this research that she developed well-known Arton-Jones equations for estimating energy requirements in hospitalized patients. These formulas are still used today, both in the US and globally. But then she changed sort of directions of what she was doing in her career. She is now I'm not going to go everything because she's got some things to tell you, but she is now the owner and nutrition therapy specialist focusing on GI disease and home, parental, and enteral nutrition. She has authored or co-authored numerous peer-reviewed publications in professional journals. She is the author of Outcome Nutrition Care, GI, Metabolic, and Home Nutrition Support, and it's in its second edition. And at lunch today, she gave Kelly a copy, so you'll get to ask Kelly to read that. She holds academic appointments as adjunct professor at Texas Tech, Rutgers, and is preceptor for several students through the years at Texas Women's University and Southwest School of Allied Health. I will let her tell more about her history and how that's influenced the development of dietetics through the year. Carol, as mentioned, is a fellow of the Academy of Nutrition and Dietetics, American Society of Nutrition, Parental and Enteral Nutrition, and the American College of Nutrition. She's received numerous awards from the Academy of Nutrition, including the medallion that's been mentioned, and Excellence in Entrepreneurial Practice Awards. And not only has she been recognized by the Academy, but by many other universities. In 2023, Carol received the Chancellor's Alumni Award from Texas Women's University. I'm pleased to present Carol Arton Jones, a friend and a great colleague.
Thank you. I've got one. So. Well, you know how dietitians are, so just FYI, I've known Carol Shanklin 72% of my life. So that's kind of a long time, and stop calculating now if you are, so yeah. Well, it's such a pleasure to be here and to be invited by these two. It was just, I think Carol Shanklin said, I really need to talk to you, and so I thought, that dumb exam has come back with a negative, but no. She asked me to do this along with Kelly, and it's a lovely honor, and especially knowing that some of the family members are here, so that's exciting. So, you know, it's Oh, here she is. There she is. I'm sure we ran into each other. So the reason why I named this talk, um, my art teacher was right, is because I wanted to be an artist. In fact, I thought I was an artist. So in high school, when people were working hard on taking their science courses to get ready for college, I was taking handicrafts, ceramics, woodworking. I just thought I was going to be an artist. And I have something for you at the end, so you can judge whether my art teacher was right or not. But I went to her and I said, I'm going to be an artist. And she said, oh, have you looked at anything else you might want to look? Is there anything else you're interested in? And I said, well, I do like the home economics stuff in nutrition. She said, good, go for that. So I would never have thought that that would be such a good decision, but it turns out it was a great decision. So, since this is a lecture, you got some learning objectives, but you can look at those later. And then these are my disclosures. So my plan was to be an artist, but reality was that I needed talent. But you can always be creative. So I want you to, as we go through, I want you to kind of look at these stars as they're going to be the way that I think we can, where my points are for you. Now, maybe this explains why I didn't make it as an artist. So I would have been a great graphic artist, as you can see here. But the reason why I have these all connected is because I went from the hospital to the burn unit to research to home nutrition support to now GI. But the goal was to show you that these things are all related to each other. Okay, hang on. This is what dietitians looked like in 1978. So hopefully you can pick me out, but this was my first job at Parkland Hospital as a clinical dietitian. So when I first started, clinical dietetics was where you wanted to go. You wanted to get a job at a hospital, either clinical or administrative. Well, having worked with Dr. Shanklin, I just thought administrative was the way to go, but it wasn't available. So I took a clinical dietitian position. What a great thing. So for students, if you're dead set on something, you might be surprised how your career changes over time. And this was 1978 that I met all these people, and we meet at least once a year for dinner. So it's been a few years that we've been getting together. And gosh, they actually even tore down Parkland Hospital, but there's a new one and it's pretty. So you are probably studying as students, and those of us who are dietitians, we know about nutrition support. I started, as I said, in 1978, and they gave me, the new dietitian who was just hot off the press, the tube feeding floor because nobody else wanted it. If you think about today, it is called enteral nutrition, and dietitians today love working with enteral nutrition because we are so important there. In fact, dietitians today place feeding tubes, whether in the ICU or even on the floor. They write orders, they assure placement, they manage home enteral nutrition programs. In fact, there was a lecture I recently went to at Aspen about how dietitians can actually remove a tube in an outpatient setting. So I went from the person, they were like, ooh, you take that, we don't like that floor, to it being such a wonderful thing in a short time. And then parenteral nutrition, which we called TPN at that time, total parenteral nutrition, had only been around really about 12 years. And it was only available in ICU units and in the burn unit. Those were the only places. When it came to enteral nutrition, tube feeding products, there are so many companies today. And I could only think of two, but there probably were three at the time that I was there. But Anybody know about blenderized tube feedings? Are you familiar with blenderized? Yeah. Yeah, well, you are, yeah. Anybody? Yeah. That's how we did it. Blenderized tube feedings are the latest thing. You take real food and you make up a enteral feeding formula. That's how we did it. That was feeding patients in when I first started. So I remember doing that and the formulas that we had. So because there weren't many choices of formulas. So that's how things have changed. Also, nutrition assessment has changed. A lot of you here in this room may have heard nutrition assessment and you think, oh yeah, that's something that's always been done. But this is the pivotal paper from JPEN in 1977. Actually, this may be a different journal, but it was also in JPEN. George Blackburn, Bruce Bistrian, these were two of the key doctors that started nutrition assessment. And honestly, nutrition assessment, we really didn't know what to do. So what did we do? Well, we did everything. You can't see it as well up here, but we did height, weight. We calculated their calorie needs, their weight as a percent of ideal body weight. We did a lot of skin fold measurements. We did lots of levels, creatinine height index, serum albumin, which we know now is not applicable to nutrition assessment, transferrin, total lymphocyte count. There were even those of us going around and doing the skin hypersensitivity test to see if people reacted. So that, for looking for immune status. So that is what we did in this is when that came out in 1977. We thought, oh my gosh, we're going to implement that at Parkland Hospital. So here we are implementing it at Parkland Hospital. Yes, there we are doing skin fold calipers, but do the dietitians go up and do the calorie counts today? I mean, we didn't actually have technicians to do that at the time. So this is us talking to a patient and doing a calorie count on the patient. But this is a patient, we're doing the calipers. I am sure I am doing that wrong, but it looks great in the picture, don't you think? I remember that guy so well. And then, so that's what we did. They gave us a lineup of 18 things to do. We did 18 things to determine what patients needed. Now, this is actually turns out to be my first publication, and it was in 1982. Now, the reason why that publication was done is because I had two patients that I was following. Both had had what we would call now gastric bypass surgery. It was called gastric partitioning. Both of them lost a lot of weight, but they couldn't do anything. Both of them were basically unable to function. And I kept saying, these people need nutrition. We've got to feed these patients. But you know, they were losing weight, which was our goal, is weight loss. Well, as you can see here, I just kept saying, please, let's place the tube or let's start parenteral nutrition, because probably parenteral nutrition would have been better with the fact that they had had the gastric surgery and we didn't really do J-tubes at that time. Well, what happened here is Dr. Feit, who was a neurologist, realized that there were neurological complications from malnutrition caused by the fact that these people were, in fact, malnourished. And so they wrote this up and said that this was one of the first times that you had seen the effect of starvation on somebody who had been formerly obese. My takeaway point for you here, my star, is that you don't know what you might be doing. I just thought I was trying to get this patient fed, but somebody realized that it really needed to be done. It was an important point, and we can't, the malnutrition that occurred it turned out to be a reason for a neurological deficit. So we know now that we have to be very careful in caring for our post-bariatric surgery patients. And then the Parkland Burn Unit, I moved to the Parkland Burn Unit, still staying in Parkland, but got to go, the burn unit dietitian left. And so I went to the burn unit. I still kept the tube feeding floor because still nobody wanted the tube feeding floor. I liked it. I thought it was great. So, and this is one of my cute little patients. Actually, she hated all of the food. We messed it up a little bit to pretend like she was eating, but we tried. So cute. But I had adults and pediatric patients, and when I got there, you know what they tell you is you're going to calculate the calorie needs on these patients. We use the Carreri formula at Parkland, 25 times weight in kilograms plus 40 times percent burn. And just in case that's not enough, we add 20% more to that. Those of you who calculate calories now are probably going, wow, that's a lot of calories. So here's somebody that I just, he weighed 70 kilos and he had a 40% burn. So he needs 4,000 calories per day. Now, he may need 4,000 calories a day. She could be short, she could be tall. We didn't care about any of that. All we cared about was their weight and their percent burn. So I calculated that every day. Some days people needed 5,000 or 6,000 calories a day. Can you imagine? And I could not get that into the patients. It was, I tried so hard. I calculated every day and I was always a deficit. But the patients kept getting better and going home. So I said to the doctor that I worked with, do you think they really need these calories? What should I do? How can we know? So Dr. Charles Baxter, who was at Parkland Hospital, said, measure their metabolic rate using indirect calorimetry. And then he went back to his thing. So I was like, great, okay, what's that? So I found out what it was, because that's what they do. And so I wanted to talk to you a little bit about energy expenditure because it's absolutely one of my favorite topics. Energy expenditure in the body is the maintenance of body functions. It's dependent upon a constant amount of voluntary and involuntary energy expenditure. And it's expended in the human body for everything from active transport, breathing, contraction of muscles, specific dynamic action of food. And here's some of the components that make up energy expenditure: age, gender, your body surface area, height to weight, your activity, your size and your stature, race, and other things actually make a difference, climate and smoking. So these are all points that have been studied using indirect calorimetry and have been proven to have an effect on energy expenditure. Now, the most basal metabolic rate is really the basis of energy expenditure. So it's 60 to 80% of your calorie needs. So for students on the Saturday that you don't have to go to work and you just lay in bed and you're like, this is the greatest thing, I don't have to get up, that's your basal energy expenditure. And so when you're, so we measure really resting metabolic rate, because I don't come to your house and measure you like that. I wake you up. So that's about 10% above basal, and that's what we can get when we measure energy expenditure in free living people. Now, that's just resting, so we can't account for the thermic effect of food. People have tried, and I might have a little data on that to show you. But we have to add for the thermic effect of food. We have to add for activity. But if you're not well, then we add something for disease or illness. So the basal metabolic rate, or the basal energy expenditure, is just the minimum amount of energy expended over 24 hours. And we really don't get to basal when we have studies that measure this unless it's in a room. And there are some rooms that are made just for this, and they can measure your basal energy expenditure. But what you typically see on a outpatient basis are what I wanted to do was resting energy expenditure. Now, here's the thermic effect of food, and it accounts for the cost of consuming, digesting, and absorbing food. So there is some energy expended in that. Let me see if I have the next slide. Oh, yes. So what increases energy expenditure? Well, spicy foods increase energy expenditure. If you Google that, you will see that some people just think that's the greatest thing ever. It's about a 1 to 2% increase in your energy expenditure. So you're going to have to eat really, really spicy foods to increase your energy expenditure enough. Caffeine also can increase your energy expenditure. But even these, where it says meals with chili and mustard increase the metabolic rate about 33%, but it lasts for an hour, maybe 2 hours, maybe 3. Just eating mustard is not going to increase your energy expenditure enough. And there's the caffeine, nicotine, alcohol. Those all increase energy expenditure. Where we first started paying attention to this in the sick patients, though, is fevers, because the increase in energy expenditure that is associated with fever. So it's about a 7% increase for each degree of change in body temperature. So that's important to know. But if you think about that in the hospitalized patient, you say, oh my gosh, I have to be aware of my patient who has a fever so we can change their calorie needs. What do you do in a hospital when a patient has fever? Well, you treat it. So if a patient has a fever, we're going to treat that in the hospital. So that might be, so clearly, feed a fever, starve a cold. That's, if you ever wondered about that, that's what it is. But you could do that on an outpatient basis. So you can, so now we know about energy expenditure. We know some things that are a part of it. How do we figure it out? Can we measure energy expenditure? And this is what Dr. Baxter said, go measure their metabolic rate. Okay, so we measure it using indirect calorimetry. We can measure your oxygen consumption and your CO2 production, and we have equipment that can do that now. When you do study the Krebs cycle, there's a couple more things in it than here, but I have just limited it to the things that I care about in the Krebs cycle today. And have you seen on social media the picture of Dr. Krebs on a bicycle? That's one of my favorite pictures. You can find Krebs on a cycle, by the way. But oxygen is consumed in every energy-producing reaction. CO2 is produced. If we can measure that, then we know how many calories you need. So for all of us in this room who are normal subjects, we could measure your metabolic rate, and then we could use factors to account for activity and thermic effect of food and such. But if you're in the hospital, we can measure your metabolic rate. That's probably it. Your disease process is already on there. You're probably getting 24-hour feeds. So that was really helpful for me when I decided to use that with patients. And this is the study that we did comparing the Carreri equation to what we measured. Now, I'm going to show you a nifty little, large metabolic cart. I didn't have a metabolic cart. I had to have patients breathe into a very large bag called a Douglas bag. I would close it up, run to the lab, squeeze the oxygen out so I could know the volume, and then measure what was in there. I had no idea it was going to be that difficult. I think I would have thought of a very different study, but I'm glad I did it. So here's what the answer is. Not only the Harrison, we also compared it to the Harris-Benedict equations. We're going to talk about those in a minute too. But with 17 patients with burns covering 26 to 79% of their body surface area, the Carreri formula, without even the 20% that we like to add, said that they needed about 3,800 calories, but measured it was 2,500 calories. So this is why the patients were able to get better and go home, because we were recommending a calorie level based on 2 factors only, and yet we couldn't get it in them, even though we wanted to. So this changed the way we managed patients in the burn unit. So these are some of the metabolic carts that are available today. And if you read the ASPEN, American Society for Parenteral and Enteral Nutrition guidelines, these guidelines say for all critically ill patients, you should measure their metabolic rate. And this happens in a small fraction of patients. I think the reason is the metabolic carts are not that expensive. I mean, a $25,000 to $50,000 metabolic cart, now that is expensive, but think about it in the scheme of things. Think about it in being accurate in how many calories you give this patient. You could save hospital days. So those of you who are out there going into this, we do have metabolic carts that are available. So you might have to be one of those that becomes a champion for these. And we got one. So I was so excited. This is me measuring a patient. Anybody in here who is clinical knows that I should have had my bangs covered, but it didn't look as good with my whole face covered as with my bangs showing. And at that time I was just Iriton, so I needed to look a little better. But I just wanted to show you that we were able to do a lot of studies using indirect calorimetry. We looked at whether or not burn size made a difference in energy expenditure. Burn size did not make a difference in energy expenditure. That was such a surprise to me. Why is that? Because they cover the burns as soon as they can, either with the patient's skin or with a burn covering. But we did notice that nitrogen excretion in the urine was something that you could follow. We also looked at, that's the one on the nitrogen excretion. We also looked at respiratory quotient. That's the ratio CO2 to O2 to see if we could be more effective in making nutrition support regimens at the time. So I was able to do quite a bit with that. So I was at Texas Women's University. I had finished my master's and I was just fine, except that this guy, who Carol Shanklin knows as well, was my major professor, Dr. George Liepa, and he said, "You need to get a PhD." And I said, "Do they sell them somewhere? Because that is what I want." And he was like, "No, it'll be easy." Well, it is not, in fact, easy. But it was so wonderful that I did that. And I said, well, I do have something that I'm interested in. I am wondering why Harris and Benedict made this equation that we all use in calculating calories. They used height, weight, age, and sex. They had people come to their place. They measured their metabolic rate, and they used regression analysis. These were normal subjects. Used regression analysis to develop equation. Can we do that? And we just add some factors for illness and injury? And that sounded kind of reasonable. And so that's in fact what we did. But before I go on, is anybody using the Harris-Benedict equation at all? Are you familiar with it? Well, it's only about 115 years old. This is how they did it. It wasn't exactly the same as what I did, but I kind of felt like that I was doing that. But they used the Douglas bags. They did not, in fact, have a metabolic cart. They used the bags, and as you can see here, I was so excited to find that picture. But let's just talk about an equation that was developed was published in 1919. They don't take it the day you send it in. They usually make you, play with it a little bit. So let's say they did all of their data collection by 1918. Here are the subjects, 136 male, 103 female. I'm surprised they got that many, frankly. The average weights, sorry, that is out of order, 40 to 100 kilos. The average height's 140 to 210 centimeters, ages 20 to 70. How many obese patients do you think were in this study? Very few. How many, I mean, people in 1918 were not as tall as they are today. How many people that weren't white do you think were in this study? Yeah. So you can see that this, even with thinking about that, it was probably applicable in the day, but it has been I used it. It was in that paper that Blackburn published, so we used it too. But as you can imagine, it's not applicable today. So I know a lot of people have put together ways that they're like, well, we modify the Harris Benedict. It's just not applicable. There is another one, the Mifflin St. George. You can certainly use that one. Calories per kilogram you can use as well. But really, you should measure using indirect calorimetry. So this is just a schematic of all the things that affect total energy expenditure. And again, for us, physical activity is probably our biggest iffy for us. But guess what? If you come to visit KU and Dr. Shanklin walks you all over the campus, you know you need to eat more calories that day. And if you don't, then you need to eat less. So we have the opportunity to manage what we do. Our patients, however, we can't wait to find out, as you can see, and we use these factors here for sedentary, moderate, and active to add for additional energy expenditure. But our patients, we can't wait to find out if they are going to lose weight. And they might lose weight because they've lost fluid. They might gain weight. Oh, look, this guy's great. He's gained a couple of pounds. Oh, yeah, we gave him fluid yesterday. So we really can't wait to find out if that's going to be an appropriate calorie level. So that's why measuring energy expenditure is important. So that's where my equations came from. I measured 200 patients at Parkland Hospital that were acute or critically ill. And then we decided what factors we should use. What would make a difference? So we said, well, we'll use height, weight, age, and sex. And then we'll use whether or not they were burned and whether or not they had trauma. So we gave this to the statistician, and he gave it back, and there were dots all over the page. We're like, oh no, we don't have an equation. We thought we would. I know what it is. We need to separate burn patients, because burn patients, even though we had proven that they didn't need a lot of calories, we still had it in our mind they probably need more. So we took that out. A few more dots hung out together, but we separated patients that were on a ventilator versus those who were able to breathe on their own. So ventilator dependent versus spontaneously breathing. And it was like a perfect shift. There were those who were ventilator dependent fit along one line, those who were spontaneously breathing fit along another line. It was great. And as you can see here, the factors that came up: age, weight, gender, presence of trauma, and whether or not they were burned. So I really don't care how tall you are if you are on the ventilator. That did not make the cut. Now, for the patients that you use this, it's just presence of burn. So you might have a 20% burn, you might have a 50% burn, but if your burn is associated with you being on the ventilator, you needed more calories. That's where that was. And trauma was a patient who had a trauma. For me, a trauma would be going into the hospital for anything. But we're talking about trauma. That's a significant leg injury. A patient has probably had an exploratory laparotomy. You know, you've seen them on ER. They put them in the trauma. And now the new one, the PIT. So there's an older version, the original, and the 2002 version, so either one of those can be used. The Academy of Nutrition and Dietetics did an evidence-based analysis, library analysis, and they say to use the original version. The second version was evaluated by my husband, who just loves to do statistics in his spare time. And that's a good thing, actually. And what we did in the second one was we decreased the standard error of the mean. So it's actually more accurate. But so either one of those will work. And then the spontaneously breathing patient one is here. And that was age, weight, and look at the very different factor for the weight and then presence of obesity. Now, we tested them prospectively on 100 patients and found out that the R value was very much within reason, so it's a reasonable equation to use. You don't add anything to this equation, though. There are no activities factors to add to this. You might add something to the spontaneously breathing if they're eating and doing more activities, but this is still acute care. So that was that. And then I pivoted because I decided I was taking care of a bunch of patients who needed parenteral nutrition, and I moved to home nutrition support. So that is the nutrition that we would provide in the hospital, but now provided in the home. Now, let's see, that was 91. So all these years later, it's kind of taken for granted that you can do that. But it wasn't at that time when we were really learning about people being at home on parenteral nutrition. But I have worked with a patient who's been on parenteral nutrition for over 50 years at home. That's pretty amazing. She was one of the first. So it can be used, home nutrition support can be used to complete therapy in the home. So you don't really need to be in the hospital, but you're not well nourished yet, so you can complete that in the home. We can even start it in the home if certain conditions are met. And it can be long-term or lifetime nutrition support. And as I mentioned, there's many, many patients that we know now that have received home parenteral nutrition and home enteral nutrition, but particularly home parenteral nutrition for over 20, 25 years at home, probably more than that, lots more than that, actually. So here's one of my favorite patients. He let me take this picture. He really loved being on enteral nutrition. I know he's looking very serious there, but he had a stroke. Everything came back except his ability to swallow. And he said, well, I'm going to be on tube feeding. I'm going to be the best tube feeder ever. And he was the best tube feeder ever. I mean, I did have a few concerns, but we worked through those. So he was great. But these are just the things. I'm not going to talk about those, but when you do have somebody who's on home parenteral or enteral nutrition, we have to be very careful on how we evaluate them. There's a significant evaluation of all of the factors that were related to digestion and absorption. And then with enteral nutrition, you need a functioning GI tract. And with parenteral nutrition, it's non-functioning GI tract, or they just can't get an adequate enteral or oral nutrition. And these are just some things. I wanted to put this up there that we have lots of enteral formulas now that we can choose from. However, most companies will have, most people have a DME company or a home infusion company that will provide these supplies at home, and they'll have a formulary. So many of them will have a formulary. So sometimes it's difficult to try a bunch of different formulas if they're really set on a formulary. But we have options from standard all the way to specialized. And then we have different ways we can give that. Patients at home may not want. Remember, in the hospital, they have a pump and it goes 24 hours. Or at 2 in the morning, the nurse comes in because there's nothing else to do and they switch and give them a bolus feeding. People don't like to wake up at 2:30 to do that. So we can change it to make it a very reasonable schedule at home. They can maybe sit with the family and infuse, just push in their product while the family is eating as well. Now, parenteral nutrition is different. It's when the GI tract is not functioning. It could be short-term or long-term. And a big part of parenteral nutrition is the access. So if it's parenteral nutrition, it's a very concentrated formula with dextrose, amino acids, and intravenous lipid emulsion. So it needs to go into a vein that has an ability to tolerate and accept that high osmolality. So you see all the sites where this could go, but you understand that this is a very serious way to receive nutrition. It can be done very well, successfully, but patients have to have really good care of their access. And then what we do with parenteral nutrition is we just put in what you would normally get. So macronutrients, electrolytes, trace elements, vitamins, we put it all in. And then we have to monitor them. Monitoring enteral patients at home is very different than monitoring parenteral nutrition patients at home, because we need to do some labs early on to make sure that they're stable and tolerating their parenteral nutrition well. And again, caring for that catheter is extremely important. This is a paper that I did with a friend and colleague, a pharmacist and a person on parenteral nutrition, because it's an interesting point. Now she can feel better. She's receiving IV nutrition support, parenteral nutrition support, but that changes things. Like the reception we're going to have after this, we might have a snack. She might not be able to do that. So it's very interesting when you deal with somebody who has to change the way they consume nutrients. Now, I have a lot of home patients that are on IV nutrition and they eat, and they may not need as much IV nutrition because they can eat. Same with enteral patients. Maybe they can't get enough, but they can get some. So eating and the home parenteral or enteral nutrition do not have to be mutually exclusive, but likely they are, because they can't get adequate nutrients enterally or parenterally, the normal, or orally. So you have to realize that there's a psychosocial component of this as well. And we were just talking about much of what we do very clinical stuff, but we also have to listen and do some counseling as well, because we're giving them this nutrition outside the hospital to improve their quality of life. So what can we do to continue to improve their quality of life? And then, for me, it was always about the GI tract. I just did not know, because in the hospital, et cetera, and home nutrition support. So that is not a real GI tract. And I really want to do that sometime and see if I can recreate that. But we have lots of parts to the GI tract, lots of fail-safes, but lots of places where things that can go wrong. And I gave this to the students before, and I just love this, because this is why it matters where you have problems in your GI tract, because if you miss the place where most of the micronutrients are absorbed, then you're going to have some micronutrient problems. And so that is what is so important. And then also, patients with GI problems have lots of challenges. What is it? Abdominal pain, gas, bloating, diarrhea, nausea, and vomiting. Yes, GI dietitians are a lot of fun for dinner conversation, but it works. But all of these things can lead to, if they are not treated, can lead to poor quality of life and malnutrition. So that's been what has been so fun for me, is to combine an oral diet with supplements, parenteral and enteral nutrition for patients. And these are some of the diagnoses that I might see, everywhere from diarrhea and constipation, celiac disease, gastroparesis, etc. Now, one of the areas that you'll hear a lot about now is diseases of or disorders of gut-brain interaction. We used to call these functional GI disorders, but now we know it's a gut-brain disorder, interaction disorder, and it's very prevalent. In fact, 40% or more of individuals globally have these disorders of gut-brain interaction. One of the ones that we probably know the most about, or we hear the most about, is IBS, or irritable bowel syndrome. And I deal with this quite a bit in my practice as well. The great news about this is the first line of care for these patients can be a low FODMAP diet. Now, I use this in my practice. I absolutely love it when a patient comes to me and said, yes, I've been having, I started out with you having 3s, but now I'm doing 4s just fine. So this is the Bristol Stool Scale, but this is a way for people to give you an idea of how they're doing with their GI output, if you will. So it also helps us describe the type of IBS that they have. So we have to do a good nutrition assessment on these patients. We can treat the IBS, that's great. I could treat it with diet, but I want to know if there's something else going on. Do they have celiac disease? Do they actually have some inflammatory bowel disease as well? So we have to take really good care of these patients, and then psychosocial components as well, and screening for eating disorders. So that's important as well. And if food is giving you problems, you can begin to have some disordered eating. So we have to be very aware of that as well. My favorite thing is this, there's medications to treat it, but the diet, the FODMAP elimination diet, is about 70 to 80% effective. Most medications, a great medication is around 25% effective. So this tells you we can make such a difference with diet, and we can do a complete elimination diet, or we can do a more modified elimination diet so that we can treat the patient where they are. If there's somebody that is already kind of in that elimination phase and we feel like they're eliminating too, we could just do a more modified called gentle FODMAP diet. And there's some of the medications that are used, but the diet works great. And then there's other things that people can use, like some nutraceuticals, stress management. They do not recommend testing for food allergies and food sensitivities in all patients. I just wanted to remind you that food allergy testing is not food sensitivity testing. Food allergy testing is to look at the top allergens for patients. And the gold standard for doing that is give the patient the food, and if they have an anaphylactic reaction, don't give it to them again. Actually, it's not quite that bad, but the best way to do that is to actually have the patients try the foods in front of you. Mentioning this because there are a lot of food sensitivity tests on the market for individuals to buy. They are not accurate. These food sensitivity tests only tell you what you've been eating, doesn't tell you what you're sensitive to. The only way you know that is to do an individual test and elimination and reintroduction. So I think it's important to be evidence-based. That's for nutrition, we have to be evidence-based. We have to understand diet well, understand our role in helping improve health and quality of life. And really, no one knows more about food than dietitians. Although maybe ChatGPT is getting there, but we still have to check. But they come to us because somebody has given them a paper to do. Somebody has said this I don't know if you really have anything, go see the dietitian, I can't help you. Or they've said eliminate these groups of foods. We know food, we can make a difference there. There's some woo therapies. I got that from one of my friends, woo words and woo therapies, but I just want to warn you about those. Immune boosting. Nothing can make your immune cells boost. I wish there was. We would have doing those. Leaky gut. No gut has a hole in it, and it's called leaky gut. That's called, you need to go have surgery. Leaky gut is just a term that people have coined for bacterial translocation and such. So be very aware of those. Adrenal fatigue. That is not a real medical condition. Gut microbiome testing, oh yes, you can still send a stool sample in, you can get your gut microbiome tested, and they're going to give you something back, and now what do you do with it? And that's a problem we don't know today. We're working on that, but we don't know today. Also, a stool test is great. That tells you what microbes you had in your stool. Doesn't tell you anything about the microbes and bacteria that you have in your intestinal wall, which is about 50% of it. So my takeaways are registered dietitians are a key member of the healthcare team, and there are many, many opportunities for dietitians. You just have to make your opportunity. Mentors are very, very valuable. Like Dr. Carol Shanklin, I thought, well, I'm going to get a master's degree. She was so young and already had her PhD. I could at least get my master's degree. So I left Texas Tech where she was, and I moved to TWU, and I got a letter welcoming me to TWU from Carol Shanklin. I was like, did I send my letter to Texas Tech? And she moved with me. So clearly she was meant to be my mentor. But I've had others as well. And if you don't have one, get one. And that's why my email is up here. If you need a mentor, if you need somebody to run things by, I mean, I can do that. I'm happy to do that. And right now, we have to fight misinformation as much as possible. It's a really crucial time for you to be evidence-based. So very, very important. And then here's my Food for 50 book. I just have to say what an honor it has been to speak at the 49th Annual Grace Shugart Lecture Series. There it is. There's her name. That lives at my house. I didn't just see that on the internet. I have that. I use that. The 4th edition, and apparently there's been 1 or 2 more, or maybe 9, but oh boy. All right. And then here's the question. So this was my senior art project. And this is when she said, maybe do something else. But I don't know. I don't think it's that bad. But anyway, thank you, Dr. Kelly Whitehair, and thank you, Dr. Carol Shanklin. And I have enjoyed being part of your group today at K-State. So thank you very much.
And thank you. We'll open it up to questions. Does anyone have a question? If anyone's on Zoom, we do have someone monitoring it, so you're welcome to kind of raise your hand or put a comment in, either one. Do you have any questions from the room? None. Oh, here we go. Oh, I need you to ask one.
Back to when you were figuring out the equation for the burn unit, did you say that on the ventilator increased energy expenditure or decreased it?
Increased. So I didn't really say that. But it seems like that they had increased energy expenditure, so that so she asked on the when patients we were doing the equation, were ventilator dependent patients, did they have higher calorie needs? And they did. And so it kind of makes sense. You have a reason that you can't do your work of breathing. You have increased energy needs, and the ventilator is helping you to be able to manage that. So yes, so you might, if you could breathe normally and you had a 40% burn, you were fine, but you didn't have an inhalation injury. Maybe your burns were more superficial. So it really, that ventilator tended to be a big identifier. And if you think about it, patients who are on the ventilator are in the ICU, or at least the step-down unit. So Thank you for that question. That's a great question, and I wish I would have said that. I know she had questions.
Definitely. And FYI, RDs, I also do have certificates on paper too, and you'll get an email follow-up for your continuing ed certificates.
You talked about low FODMAP and
Uh-huh.
IBS and treating patients with that dietary intervention.
Mhm.
Do you have any concerns of using low FODMAP long term in case of any micronutrient deficiencies?
Absolutely. It is the low FODMAP diet is a elimination diet that lasts maximum 6 weeks. It was never, this is why the dietitian is so important, and referring to the dietitian is so important because I have many patients that come to me and say, I've been on this low FODMAP diet for 6 years and I don't think it's working. That's because they got a low FODMAP diet. The low FODMAP diet, if you remember, there were 3 steps. You eliminate high FODMAP foods. You'd have to look at that real quick. You eliminate high FODMAP foods, you reintroduce foods, and then you personalize your diet to you. So absolutely, and the 2 nutrients that seem to be the biggest challenge would be calcium and fiber on the low FODMAP diet because we're limiting lactose, and so limiting some of the higher lactose containing dairy products, and then we're limiting wheat, which is whole wheat tends to be the place that most Americans get some fiber. But the low FODMAP diet has never been meant to be a diet forever. It is an elimination diet for maximum of 6 weeks. I mean, if I have somebody who's like, well, I was on vacation, I didn't do it very well, and I want to keep going, they can keep going. But just if they, maybe another month, but then I'm like, well, you're already adding back, so let's just coordinate that. So good question, and that is why dietitians are so important. We're not a piece of paper, and anyway, okay.
Hello, how are
Hi,
you?
good.
My question was about patients that are having nutrients like taken in without eating food. Do their what is it called? Salivary glands?
Oh, yes, oh.
Do they stay the same or do they change over time? Do they go away, or
That's right.
how is it like not eating anything through your mouth?
Yes, that is, so if you can't eat, do you get hungry? Do your salivary glands produce saliva? Does your stomach growl? And the answer is all of those things may happen. So that is one of the challenges in my early days of having people on parenteral nutrition at home. We were like, don't eat, you can't eat, don't eat. And we learned that there is a pleasure to eating. And so maybe you have a little bit more output. Let's talk about foods that decrease output. But that quality of life can be very helpful. I have a patient right now that has had throat cancer, esophageal cancer. He has a little hole right here. He has a tube feeding that he's doing every day, doing great. But he likes to eat, and he just, I think it would be difficult, but he wants to eat. And so I have patients who chew and, nicely, or I had a 7-year-old guy, so cute guy, he wanted to sit next to me, and he said, look, I just ate my food, and then I put it right here. And I'm like, that is great. Because he was able to eat even though he was on full parenteral nutrition, we did not want it to go anywhere. And he had a pretty nice pile after, I can see that now. He's about 17 now. I want to go back and say, remember you. But it's a good question. That if you do get that article that Emma wrote, you will see that it can be a real challenge for them.
Any other questions?
But that was a great thought and question.
You can go ahead and do that one real quick.
Just a comment from Samantha Khan.
Oh.
She says, excellent job, Carol. Your immense knowledge, passion, commitment to dietitians, and of course, sassy humor group, the students know why your patients have so much respect.
Oh, that's my girl. Thank you, Swapna.
You mentioned talking about like using evidence-based research and all
Yes.
of that. I feel like you kind of mentioned in nutrition assessment earlier that sometimes PCPs can just like throw the most basic stuff at you and those patients might not know. How do you suggest people challenge that, whether it comes from their education or educating the public to know to fight for like more information or the right information?
Well, uh, that is a lot. Well, first of all, if it's a patient coming to me with their microbiome test that they're so proud of, I say, well, that is really interesting. The problem is that that was your microbiome on that day, and you know it took about 5 weeks to get that back, and now it's completely different. And then we really don't know today how to use that because there's no data to show how to use that. So you've done it, now we see. So I wouldn't recommend that you do that again since it's not actionable. So I try to, with patients, I try to be very, I want to support them because they've already spent $600 on that and they're like, oh, I wish I would have seen you sooner. On the other hand, with our clinical colleagues, I think we need to be, we're on the same level as them. So I think we need to just say, in an appropriate setting, of course, not with patient right there going, where'd you get that? We have to just challenge them. Where is the data behind that? Because they may have assumed that there was data behind that when there really wasn't. And a patient may have brought it and said, oh, look how great I did, and they're using that for them as well. I spoke earlier today and I talked about the two things. If you have a GI problem, and you see even some gastroenterologists, but if you pain, bloating, gas, whatever, they're likely to say, you know what, stay off dairy and gluten for a while. There's no data to support either of those. There might be to support both of them separately if you did further examination. But when you take off an entire food group, I mean, you've taken all these, you take gluten, so that's all your breads. You've taken a lot of B vitamins out of there. You've taken fiber, the fiber person. I mean, you've taken a lot. You take off dairy, you've taken calcium, phosphorus, potassium, magnesium. So so that's one of the ways that I approach that, is just saying, taking a wide, making a wide recommendation is really not appropriate for patients. But I would say that we all in here have to walk the walk and talk the talk, and that's probably, that's even hard for us because we've all got friends and family and Google.
Mhm.
So I don't know if I helped, but
But it's still like raising awareness too, because I know it's not necessarily just in nutrition as well. It can be all across healthcare.
of course, absolutely. It's
Bringing up the topic.
yes, it is. So I mean, I think it's up to us. They have to know who to go to, and I would tell you today, and I don't want to tell you this, but I would not recommend every registered dietitian. You really need to read and determine if it's somebody who is reputable, if and maybe ask colleagues too.
All right, well, thank you. Let's thank her one last time.
Thank you.
And just a reminder, we do have a small reception literally right out here. There may be students coming this way. I think they have a class in here at 5:30, so there could be some students rambling around. And again, for registered dietitians, I do have certificates as well. And if you haven't signed in, sign in, and I'll email it to you too. And thank you all, and we'll see you out in the lobby.